Now we'll be starting with the next session, Part 2 of Critical Care Hepatology, Endpoints in Critical Care. For this, may I invite the chairpersons, Dr. Manzoor Hussain Agharia, Dr. Sandeep Pandey, Dr. Pankaj Rane, Dr. Eeta Srivenu, and Dr. Vinay Thorat. Please take your seats.
Good afternoon. For the first talk, Plex in ICU, Challenges, Contraindication, Utility and When to Terminate. I invite Dr. Epan from Christian Medical College, Bangalore.
Let me thank Akash for this invite to give this talk at this conference and congratulate him for a very nice conference. The topic he has proposed is Plex in ICU, Challenges, Contraindications, Futility and When to Remember. So let me have a go. Now the management of acute liver failure, as per this article 10 years ago, 15 years ago, was supportive medical care and urgent liver transplantation. But as per this nice review by Raki and team last year, now the management includes Plex as well. So it appears that more and more plasma exchange seems to be coming into the as one of the options available to treat patients with acute liver failure. Now different volumes of plasma is used during plasma exchange to treat acute liver failure. In an adult, what is given at the bottom row, we have 5 liters of blood volume. If you take half as plasma, 2.5 liters, so then one could either have high volume, standard volume or low volume. So the different groups, volumes used. At our institution, we have sort of continued using low volume plasma exchange with our experience which we have gained. Now, this is a bit like, the situation here is a bit like Mumbai airport. As the plane lands, you can see Asia's largest slum. And most of the slum dwellers are highly unlikely to, other than watch a plane go every 2 minutes into the sky. In their entire life, they probably will not ever get onto a flight. So a liver transplant is not within the reach in a person who needs urgent liver transplantation for most people. Now, this is a problem world over, but much more aggravated in a country like India. So the access to specialized treatment is the key, and if you think about it from the kidney side, renal dialysis is available everywhere in India, while kidney transplant is in select centers. If somebody needs an urgent kidney transplant or an urgent liver transplant, the access is challenging really. Yet another evolving concept is, should plasma exchange be done for one to bridge the person towards a transplant, or should we say upfront, no, we are going to aim at improving survival with a native liver. This is a concept in evolution as well. And this algorithm where we have proposed that in the setting of ALF and ACLF, where does one place liver transplant, where does one place plasma exchange? So it appears that plasma exchange is to be done earlier in the phase of the illness. In the person who's later in the phase of the illness, liver transplant seems to be the correct treatment to do. Now, how does one, at what setting, etc., is still in evolution, and there's much to be learned with our experience. This particular study done in Tamil Nadu by the Tamil Nadu chapter of the Indian Society of Gastroenterology, in 2019 the study was done, showed that for every one patient with paracetamol overdose causing toxic hepatitis, there were 75 patients with rodenticide rat poison injection which contains phosphorus. So the paracetamol overdose is the equivalent of of rat poison ingestion is equivalent of paracetamol overdose in southern India, and I think also in Maharashtra, which is where Mumbai is located as well. And in this particular study as well, of 450 patients picked up in this time period of a 6-month study, only one patient could access urgent liver transplantation. So this is the access issue, which is a very serious problem which is faced in India. Now, these are listing criteria for urgent liver transplantation described from Amrita Kochi. We now call it the Kochi criteria, specifically for patients with rodenticide-induced hepatotoxicity, and by some severe parameters, that is either a MEL score of 36 and above, or an INR of more than 6, and encephalopathy. Using their data set, they felt that all these patients should undergo urgent transplant if possible. So in this, the survival from the Amrita Kochi study of the patients who all met these severe criteria, Kochi listing criteria, 14 patients underwent liver transplant, survival was 86%. With those who could not have liver transplant met this criteria again, that is standard medical care, there were only 8 patients, but none survived. The survival is nil. At CMC Vellore now, the data shows that in this group of patients, none of whom underwent liver transplantation, with plasma exchange, survival has become 60 to 75%. Now, the Tamil Nadu chapter of ISG has now brought out these guidelines on managing the rodenticide poisoning, the focus on saying on non-transplant treatments. So these are the indications for PLEX. So it is an INR of 4 or more, or serial worsening INR, or the presence of encephalopathy. And the contraindications were hemodynamic instability and active sepsis. Now, there are 2 techniques of plasma exchange possible, and by this analysis from our department, Santosh has shown that the survival is significantly better in patients with severe alcoholic hepatitis by the centrifugal technique of plasma exchange compared to the membrane plasma exchange. So we have, and most centers in India were preferring the use of centrifugal type of PLEX to treat liver failure patients. We believe one of the reasons for this survival benefit may be the low flow rate of blood processing during PLEX with centrifugal technique. The mean was 35 ml per minute, while with membrane in the data set, the mean flow rate was 125 ml per minute. Now, the biggest challenge really is in selecting which patient with ALF to treat with PLEX. And again, as I said, it's an evolving field. And I think here it's pertinent to share this small story. This article in the NEJM talks about how the first president of America, of USA, died, George Washington. So he had retired as a president by then, and he, at the age of 67, he developed one fever and sore throat, and within 24 hours he died. So 2 centuries later, it is felt that he died of acute bacterial epiglottitis. Now, this is an era where there were no antibiotics as yet, and there were no terms like inflammation as yet. These are all, that's the time period. And of the 3 experts called, one of them was in favor of bloodletting. And in 3 sittings, the president had 40% of the blood volume let out. And in fact, when he died, his friend in France, that is Napoleon, then ordered for all the flags to be lowered in France in respect of this president. So the 3 doctors felt they owed it to the public, and the next day they wrote in the national newspaper the sequence of events, how they treated and what the logic was. But within another 24 hours, the whole thing, the public outrage said that the doctors killed the patient. So 2 centuries later, plasma exchange, which is one form of blood purification or blood cleansing, has now become standard of care for a variety of diseases. I'm giving an example of Guillain-Barré syndrome, etc. to say. So, selecting the patient and selecting what type of treatment to do is something which we can easily do wrong, and maybe we are doing wrong even in our liver patients now, as we are learning along the way. So let me focus a bit on toxic hepatitis. The problem in the West is paracetamol overdose, and in big parts of India, it's rodenticide injection. But there are three phases of illness, as you know. The phase 1, where there is no symptoms or mild GI symptoms. Phase 2 is only coagulopathy, no encephalopathy, that is severe ALI. And phase 3 is encephalopathy, that is ALF. The EASL guidelines, Dr. Venden is the senior author, states that in ALF, the treatments advocated are liver transplant, apart from the standard management critically ill patient, PLEX, especially if no access to transplant, and CVVH. However, the change which we have been doing in Tamil Nadu, which is now advocated by the government as well, is that we moved it to phase 2. In severe ALI as well, we have started doing plasma exchange, so we have moved it earlier into the illness. So how do we select a patient? Who is the patient where it's optimal to do plasma exchange? Now, this analysis by Vijay Alexander from our unit showed that in patients who are not ventilated, when we use low volume plasma exchange, no patient had TRALI, and there is a very small number of patients had transfusion related circulatory overload. Now, these are all very severe, potentially fatal complications, which happens with use of so many blood products. So thereby, the first way to select a patient is to consider using a person with liver failure who's not ventilated. So I'm saying we are moving more and more earlier into the illness. In such a patient, it's pretty easy to do the plasma exchange. 2, patients with ALF have vasodilatory shock. It's equivalent to what is seen in sepsis. And as I mentioned in the guidelines by T and ISG, hemodynamic instability was kept as a relative contraindication. Now, this is a work in progress. Ashisha is in the audience today, I think. So, 7 centers in India, this data is being collated on hepatitis A-related acute liver failure, which is now a problem in different parts of India currently. There's outbreaks going on. In the retrospective study, this turns out to be currently the world's largest number of such patients who are having PLEX done. All patients have ALF. That is study inclusion criteria. They are all encephalopathic. Of the 82 patients, 60 were not on inotropes. Now, when all patients were analyzed, there was no difference in the survival between the PLEX group and the standard medical therapy. As a background, we know that in the King's College criteria for listing for transplant, non-A, non-B is taken as King's College criteria. That means hepatitis A is a benign etiology of ALF, where recovery can happen spontaneously. But still, a proportion of people do die or need urgent transplantation. However, in this data set, when we take patients who are not on inotropes, that is 60 patients, now there is a significant difference in survival in those who are underwent PLEX versus only SMT. So thereby, patient selection again, a person who's not on inotropes and not ventilated, again, is a easier patient to do. Now this patient is again encephalopathic, as per that data which I showed, but as I mentioned, we can move towards ALI itself, is what we think. To prolong the phase of avoiding encephalopathy, we are very keen, and thereby it's now come out again in the government's guidelines, to avoid sedatives if possible in people who ingest rat poison, because that itself can trigger encephalopathy. So this is the sort of how we have been moving the field earlier into the illness, in this serious illness. Now at our department at Vellore, we have been increasingly doing plasma exchange, encouraged by the survival, at least what we perceive as survival with the current benefits data available. Now the bottom row gives the number of liver transplants happening per year in our institution. We do exclusively cadaveric transplant. It's like UK actually, or maybe 1 or 2 patients may have had LDLT. You can see that in contrast to the number of liver transplants, the number of plasma exchange patients are increasing every year, and we would have reached now near 700. Of these, only 39 patients were treated in the ICU. The remaining 620 are treated either in the HDU, or we're calling it a highly monitored area. That means we are catching the patients earlier and earlier in the illness, and they do not need ICU care at that time. Such an approach seems to be finding favor with the government, because when we have large outbreaks of hepatitis A or of almost epidemic proportions of rat poison ingestion, it's much easier to implement flex rather than urgent liver transplantation for these numbers of patients that we handle. This data shows that in Tamil Nadu, this implementation is successful. Now, you know that in UK, we all know that I think the country is divided into 7 regions within which liver transplant patients are triaged to. In Tamil Nadu, there are 38 districts. Within each district, the patient is triaged to those who need plasma exchange or not. And between the year 2022 to 23, 1,237 patients underwent plasma exchange in government district medical college hospitals for rodenticide poison. While across the state of Tamil Nadu, 3 patients underwent urgent cadaveric liver transplantation. What are the contraindications? If somebody's got unequal pupils or dilated pupils, we know it's irreversible brain damage, and it would be an absolute contraindication. While multi-organ failure, the more the multi-organ failure is there, the question is, should we do? It's a question. While active sepsis, we would take it as a contraindication. Hemodynamic instability and recent upper GI bleed are relative contraindications. last slide. When is it futile? When to terminate? I'll turn it the other way around. When is it of utility? So this data has just now come out in the December issue of the IJG, where Vijay Alexander has analyzed our data set and shows that by the third session of plasma exchange, if there is a decline in MELD by more than 20% in the patients with rat poison induced hepatotoxicity, then there's a very good chance, the numbers are there, that the person will survive without a liver transplantation. While those who do not respond could be considered for urgent liver transplantation. Thank you.
To deliver the next talk, we would like to invite Dr. Vaishali Solam, who is going to talk on assessment and the choice of vasoconstrictors in critically ill cirrhotics.
Good afternoon, friends. Thank you, Akash, for making me a part of this. The non-transplant outcomes is an area of interest for all of us, intensivists especially, because the real work lies there. So I've been given 15 minutes for a topic which can be a theme for a critical care conference, that is assessment of hemodynamic status. And the second part of my talk is choice of vasopressors, the first choice of vasopressors in critically ill cirrhosis. A major part of my talk will be about the assessment, because that's where the biggest pitfalls are. There is fair degree of clarity in the first choice of vasopressor to be used in septic shock and cirrhosis. So now, we all know the underlying cardiovascular pathology which is inherent to cirrhosis. There is peripheral vasodilation, splanchnic pooling, there is third spacing, the central blood volume is low, and of course the cirrhotic cardiomyopathy, which may prevent the patient from mounting a higher heart rate. And then a very important and often neglected aspect of cirrhotic cardiomyopathy, that is diastolic dysfunction. This is underdiagnosed, and I feel it is not given enough importance in patients in the ICU, especially the cirrhotic ones. Now, normally, in a non-cirrhotic, when he's septic, I would teach my students, look at the peripheries, they'll be shut down. Look at the capillary refill time. It is going to be prolonged. There will be tachycardia, of course, hypotension. That's intrinsic to the sepsis 3 definition of septic shock. And about half of them would be fluid responsive. Now, when you look at the same parameters in the cirrhotic population, you may not actually have a prolonged capillary refill time. That's because of the peripheral vasodilation, which is intrinsic. They may not mount a tachycardia response. Hypertension has to be there, especially when you are trying to classify the patient as septic shock. And maybe less than half are actually fluid responsive, though we don't have enough evidence in the cirrhotic population. So a lot of all these parameters, which I'm going to talk in the next 5 minutes, have been validated in non-cirrhotic populations. And that's where the limitation is to extrapolate them into cirrhotic population. Now, when we come to endpoints of resuscitation in the ICU, the Andromeda shock trial told us, look at the capillary refill time, and that is good enough a clinical marker that you are on the right track and that you have achieved enough resuscitation. Then the other parameter is more than 20% lactate clearance for 2 hours. Again, there's a limitation to this in cirrhotics. If you can achieve a urine output of more than 0.5 ml per kg per hour, yes, that's also another endpoint in septic shock in the ICU. But in cirrhotics, there can be more than one mechanisms involved, and that probably may not be the output that you would get. And the biggest area of controversy, what is the MAP that one should target, and is pressure the ideal thing to target? And I'll come to that in the last half of my talk. And of course, in a non-cirrhotic, one would want reversal of encephalopathy, but probably in cirrhosis that is not possible to achieve just by resuscitation. Now, coming to assessment of central blood volume. Mind you, I do not mean assessing the central blood volume. Here, what I mean is assessing volume responsiveness, because the patient can be hypovolemic, euvolemic, or hypervolemic, but they yet still could be volume responsiveness. And what we have learned over the last 2 decades is that what is important to assess is the volume responsiveness, not just the volume per se. Now, in the era where we want to go more and more non-invasive, we have a few tests which we could rely on. One is the passive leg raising. Mind you, when you do the passive leg raising, you have to be able to monitor the cardiac output. So you should have a 2D echo probe which is monitoring the LVOT VTI. You do the passive leg raising and then again monitor the LVOT VTI, and if there is a 12% jump in the LVOT VTI, that tells you that yes, the patient is fluid responsive. So there has to be some mechanism. Either you have a cardiac output monitor or invasive one, or you do it echo guided, which is far more easier than putting an arc line. Then IVC diameter and collapsibility. Now this has undergone a major shift in the last 2 decades. We started off with very high reliability on the diameter and collapsibility, both put together, not individually. But we have over the last 2 decades realized the limitations. We know now that the area under the curve for this parameter can be anywhere between 0.65 to 0.55 sometimes. So there are pitfalls to this. And the new entry is the LVOT VTI. Actually, now my ICU rounds do not start without the echo machine being with me from one patient to the second patient to the third patient. It has become an indispensable tool in intensive care unit to have a good resolution ultrasound machine capable of doing a focus and an echo at the same time when I want to assess a patient. Of course, we are intensivists. We want objective data. We don't want to rely on somebody's expertise. Ultimately, echo will be expertise dependent, and there will be inter-observer variability, and plus echo is not continuous. So I love my continuous invasive parameters, which are the dynamic parameters, stroke volume variation, the pulse pressure variation, cardiac output, continuous cardiac output monitoring, whether you do it by the flow track or by the PICO, which is far better than the flow track because it's more standardized. If I can get some more numbers like extravascular lung water index or ITBV, I will be more happy. And then the last is the end expiratory occlusion test, which I can also attempt, but there has to be an arterial line measuring the cardiac output in situ to be able to interpret it. So in a spontaneously breathing patient, I can't use these invasive parameters because they are dynamic and they need a patient to be completely sedated and not having spontaneous breathing. So in these patients, CVP, we all know it's completely out. In fact, many units don't even monitor the CVP despite the central line being in situ. IVC collapsibility, as I already told you, yes, IVC collapsibility index of more than 40% used to be considered to be quite a reliable parameter for volume responsiveness. We have learned now that it cannot be as reliable. The AUC is 0.7, and especially in ascites, it's absolutely a futile parameter to look into it. There was one study which actually compared IVC collapsibility with LVOT VTI, and they found that nearly 20% of the patients, they couldn't get a window to see the IVC only. So that is also another problem. While LVOT VTI almost more than 95%, the window was not a problem. So now let's talk a little bit about this new baby, that is the LVOT VTI. Now, what is LVOT VTI? It's basically measuring the cardiac output just above the level of the aortic valve. Now, it's done by a simple echo probe, bedside transthoracic echo, that is. I'll measure the LVOT VTI, then give a volume of around 500 ml, anywhere between 250 to 500 ml. It will depend upon the patient's weight, so it is not necessary that to 40 kilo you give 500, anywhere between 300 to 500 ml over 15 minutes, and then again measure the LVOT VTI. And if I get an increase of more than 12 to 50%, then I know that the patient is volume responsive. And the area under the curve for this parameter is brilliant, which is 0.9. Here, it doesn't matter if the patient is spontaneously breathing. It doesn't matter if the patient is in arrhythmia. If there is AF, you might have to take 5 or 6 readings, but it is still reliable. Also, it doesn't matter if the tidal volume is less than 8 ml per kilo per hour, which is a requirement for all our other dynamic parameters. That is, the tidal volume should be 6 to 8 ml per kilo per hour to be able to interpret them with reliability. And almost always you will get a window in the ICU. It has the best AUC of all the parameters. The only thing is it needs training and it is not continuous. So you will have to do it repeatedly and with the same level of competence as throughout the day. So this is my new, the tool, Focus plus Echo. Oh, 5 minutes. Okay. So you do a focus, look at the IVC diameter, look at the IVC collapsibility, LVOT VTI, and then look at the B lines if there are B lines on the USG. And you can come to a good conclusion about whether the patient is in fluid overload or there is a scope to give fluid to the patient. I'm going to skip how to measure this LVOT VTI in the interest of time. So in a ventilated patient, of course, I'll get my catheters in, whether it's a flow track or a PICO. I'll rely more on SVV than PPV. Then if I can get some numbers like extravascular lung water and ITBV, I may have more information to guide my fluid therapy. This is what I was talking about, the area under the curve. It's best for the LVOT VTI and it keeps dropping, and you can see for CVP it is 0.5. That means you may be wrong half the times. Now, I'm not going to go into this because this has been extensively discussed, and in the interest of time, I think I should not concentrate on this. But just one line suffices. There is a huge controversy in intensive care. Should we go liberal? Should we go restricted? And I think this is the age of personalized medicine. It has to be personalized, adequate resuscitation. We have to change the terminology from liberal and restricted to personalized and adequate. And I know it's not an easy goal to reach, but that should be the aim, to reach that goal, that is personalized and adequate. Professor Sareen has already spoken about 5% albumin. A word about the ROSE protocol. There's a huge concept of fluid stewardship in the ICU. Fluids are drugs. Drugs have a dose, they have a duration, and they should be de-escalated. So IV fluid also have a dose. In different phases, the dose should be different, and there should be de-escalation. So the 4 phases of the ROSE protocol are: first is the resuscitation, where you give early aggressive fluid management, then optimization, where you give a fluid which is lesser aggressive but still requires to optimize the patient, then stabilization, which only takes care of the daily patient's fluid needs, and at some point, the last phase has to start, and that is evacuation. This is sometimes ignored in intensive care units, and that's why I have a huge board next to every patient where every day's intake output is written, but also cumulative balance is documented by the nurses. So I come to know at the end of 4 days or 5 days or 7 days, how much is the cumulative positive balance, and then I know whether we've been going in the right direction or should I start evacuation. Mind you, in each of these phases, there is no scope for overdoing it or underdoing it. So you have to get it just about right. It's never too easy to get it right, but just about right. Because if you over diurese in the evacuation phase, you will cause another injury. So I'll skip this part. Now, the last part of my talk is vasopressors and the choice of vasopressors. So basically, the early vasopressor rationale. So restrictive fluid strategy hinges on starting vasopressors early. And noradrenaline remains the first choice in septic shock, whether it's a cirrhotic patient or a non-cirrhotic patient. And these are all the guidelines which have established this, that noradrenaline is the first drug of choice. Currently, there is insignificant data to recommend telepressin, though there have been studies, and in fact, Raki has published one study where they have studied terlipressin versus noradrenaline with good results, early resolution of shock. But I guess we need more data and more extensive data to make it as a practice-changing recommendation. Now, the other important part is timing to start noradrenaline. It's extremely important to start noradrenaline early. Now, you may ask me, what is early? So you just go, guidelines are at the end of the day guidelines. They will have to be curtailed to a patient, particular patient. So the guidelines say 30 ml per kilo per hour in the first hour fluid, does not respond, start noradrenaline, and then keep on assessing the lactates, the peripheral perfusion, and then decide whether you want to give more fluid or you want to titrate up the noradrenaline. But some patients actually, and if there are intensivists in this audience will know that sometimes it's futile to wait till that 1 hour. You continue the fluid resuscitation, but you start the NORAD at a small dose like a 0.05 or 0.1 microgram per kg per minute earlier than 1 hour. And these are especially patients who have a diastolic shock index of more than 3. They are definitely going to require, and then waiting for that 1 hour is probably, you should start at a small dose, 0.05 to 0.1. Now, there was this beautiful study from Thailand, which they documented that 5.3% increase in risk of death for every delay, every hour's delay in starting noradrenaline, and the difference was 2 hours. If it was delayed after 2 hours, there was definitely an increase in the mortality per every hour's delay. The second drug is vasopressin. Now, usually when your noradrenaline reaches level of 0.3 to 0.5 micrograms, one would add vasopressin, more so in cirrhotics because they are AVP deficient. And the AVP, then replacing the vasopressin actually sensitizes them to the respond to noradrenaline. So it's a good drug of choice to add as a second drug after noradrenaline has failed to achieve the target MAPS. Difference between vasopressin and terlipressin from an intensive care point of view is the half-life. I'll take 30 seconds more. Is the half-life, and we always like drugs which are shorter half-life as compared to longer half-life. As I said, terlipressin, probably one should be cautious, not use it as a first drug or even the second drug of choice, but we don't have enough evidence right now, and more evidence may come up, and this may change the status. It may become the second choice, but mind you, there are pulmonary side effects. This is Professor Reddy has been a part of this, just a warning about using terlipressin in AKI in grade 3 ACLF. The pulmonary side effects are more. 30% of them developed respiratory failure when it was used in grade 3 ACLF who had AKI, stage 3 AKI. So basically, if there is a hyperinflammatory milieu, which happens in ACLF grade 3, you're probably not very safe using terlipressin, and noradrenaline would be a better choice. And septic shock, again, noradrenaline would be a better choice. So I'm not going to go into this, but just one factor. This is what I want to see at the end of my resuscitation. I want to see the SVV nicely at 13. The MAPS are maintained. This is more than what it should be actually. At this point, I'll start tapering the NORAD. And this is an invasive flow track monitor. And this is the patient's monitor. where I get a good map and I've achieved the targets that I wanted to achieve, and the patient's lactate also from 10 went down to 3. Of course, there were many other measures that had to be taken to stabilize the patient. But this is the endpoint of my resuscitation. Again, MAP is not the actual target. We want the microcirculation to be actually established. We don't have any measure of measuring the microcirculation, so we are taking indirect measure of MAP. And I'm sure over the next decade, there will be some developments in this where we will be monitoring microcirculation in the kidney, in the muscles, in the skin, in the brain, and probably guiding our resuscitation based on that rather than this one golden number of 65. So thank you very much. It's a science and also an art. One has to stand bedside all the time till such time that the lactate is decreasing and the capillary refill time is improving. Thank you so much for your attention. I'm sorry for exceeding my time limits.
Thank you, Dr. Vaishali. Can we now have Dr. Madhumita for the next talk? We'll speak on early diagnosis of vasoconstrictor non-responder, definitions, tools, and implications. All to you, madam.
Thank you so much, and I thank Dr. Vaishali for covering fluids and also a large part of my topic. So I'm going to be talking about non-response. When she's already started vasopressors, she has resuscitated the patients with fluids, albumin, whatnot, and she's given you a fair idea about the assessment, perhaps in an intensivist term, but I'll try to simplify it for you. I have no disclosures. So I will be focusing not on septic shock because I believe that was the domain of the intensivist. And we'll be talking about things which are more relevant to the general hepatologist, which is HRS-AKI. How do we assess volume status in these individuals? And how do we assess the use of vasoconstrictors? And then when do we expect non-response? And with just a brief idea of non-response in septic shock. So this has been covered by Professor Sareen. In a patient with cirrhosis and portal hypertension, there is the problem of splanchnic arterial vasodilatation in both the splanchnic circulation. And of course, there's an element of cirrhotic cardiomyopathy, which is there in about 30% of all individuals. LV diastolic dysfunction is not synonymous with either a dilated cardiomyopathy. So if your cardiologist is coming and telling you that the EF is normal, therefore there's no cardiac dysfunction, please insist on asking for diastology variables, which is looking for relaxation failure of the cardiac muscle. So in the context of all this, if the patient has ascites and has some predisposition, they could undergo the entire spectrum of AKI, whether it is pre-renal, whether there's structural damage resulting in ATI, or whether it's a combination of both, where there is a problem of excessive splanchnic vasodilatation. So in this case, not only do we have to offer a preload by expanding the expected circulating blood volume, we also need to give a vasoconstrictor to counteract the splanchnic arterial vasodilatation. But that is only in patients with HRS-AKI. One thing I want to make clear to everyone in the audience, if you have 100 patients with AKI, just AKI, elevation creatinine, lower urine output, coming to your outpatient, a large majority of them, say 50 to 60%, will just be fluid depleted. They will respond to withdrawal of diuretics, they will respond to stopping beta blockers, correcting any sepsis or any cause for dehydration. The vast majority will not require this vasoconstrictor protocol at all, number one. Number two, once we have removed all these precipitating agents, we have to ensure their volume resuscitated, which means we should know exactly what a volume replete cirrhotic should look like. Dr. Vaishali has given you a very large set of hemodynamic variables, which are not really understood by the average hepatologist. Maybe more and more people are now getting familiar with these domains, but you need to know your patient is volume replete. It should not be a protocol-based albumin resuscitation. So this, if you just get these take-home messages, half my job would be done. Because inappropriate fluid and inappropriate vasoconstrictor is a predominant cause for non-response, apparent non-response. So volume expansion, whatever you want to use, albumin or balanced salt solution, and the vasoconstrictor agents together can manage HRS-AKI, which is maybe just 15 to 20% of all the AKI. So pre-renal, ATI or ATN, and you could have HRS AKI, and then there could just be functional components. So please see what is the etiology of AKI in your patients. So if there's hypovolemia, expand. Once you've attained euvolemia, attain it within 24 hours. We will discuss how to assess. And then do not delay the initiation of terlipressin or norepinephrine as per your unit's choice. Because these patients, the more you delay, the less likely is there going to be a recovery. And where you have an equivocal volume status and you're not sure whether the patient is volume replete or not, we use these dynamic tests of fluid responsiveness, maybe a passive leg raise, which will increase the preload by 300 ml, or by giving a small bolus of fluids, and then looking at the change in the mean arterial pressure or the pulse pressure, or preferentially looking at the velocity time integral, which we will just quickly discuss. Please remember, a large number of your patients may also be in fluid overload. They might have expanded IVCs with low collapsibility. They may have intra-abdominal hypertension. They will require a large volume paracentesis, and they may require diuretics. So it's not simple. You need to learn to classify what is the phenotype of AKI and what is the volume status, and then decide whether it is appropriate to use a vasoconstrictor. Once you master this, you will not have non-response. So the tools have been discussed. I will just show them pictorially. The IVC collapsibility index or the distensibility index in those on mechanical ventilation. The delta velocity time integral, which is nothing but the blood that is being pumped out of the cylinder from the LV into the aorta with every beat. So any change in this velocity time integral means there is beat to beat variability of the stroke volume. That's all that it is. So the more variability you have, the less likely that the patient is going to be volume resuscitated. So that's the way you look at it. And most important, for de-escalation, one has to keep monitoring for complications of pulmonary edema. A great way to do it is a bedside lung ultrasound. Okay, so these are the devices that Dr. Solar has told you about, but what we would prefer is just looking at a plain echo machine or an ultrasound machine, and slowly people are getting more familiar with assessment of volumes. This interesting study came from Juan Velez's group in 53 patients with an apparent diagnosis of HRS AKI, and this is at the point of 24 to 48 hours where the patient had already received albumin for volume expansion. So they found that a large number of patients would still remain volume depleted based on just IVC and collapsibility, and some of them would be fluid replenished or volume expanded. So how do you distinguish, and why is it important? Because in the patients who are still volume depleted, you will need more albumin, more volume expansion. In patients who are having a small IVC and a small collapsibility, it means that the intra-abdominal pressure is high, which means they might require a large volume paracentesis. This is very rare. Please don't go too much by this. And in the patients who are volume deplete, they will require a vasoconstrictor, whereas those who are already having volume excess and are at risk of pulmonary edema, they need diuretics. So don't blame the vasoconstrictor terlipressin for pulmonary edema in those cases. De-escalation is paramount in patients once you've achieved volume status. You don't have to continue with those boluses of albumin that will be personalized and given as per day-to-day or even 6-hourly assessment of the patient's actual volume status. So the vasoconstrictors that are relevant to HRS AKI would be noradrenaline and terlipressin. Vasopressin and norepinephrine for septic shock, of course, come in a secondary domain. Fewer and fewer centers, I'm not sure how many people are even using octreotide and midodrine these days. We have focused mainly on terlipressin in our unit, followed by norepinephrine in those with terli contraindications like cardiac dysfunction, arrhythmias, bradycardia, etc. So the definition of non-response. So this is the second part of the topic. What is the definition of non-response? So responder is one where there's complete reversal AKI. They could be either partial or complete. A complete response is those in where the final serum creatinine level is within 3.3 milligram per deciliter of the baseline. A partial response would be those where there's a regression in the AKI stage as per the attempt, but the final serum creatinine is more than 0.3 milligram or whatever was the baseline, which could be the last known creatinine within the last 3 months or the creatinine at the time of admission. And a non-responder is where the creatinine does not decrease or actually increases from the baseline. So this is a meta-analysis by Professor Singhal here, and the purpose was to look at whether treatment with terli versus norepinephrine, so choice of vasoconstrictor. So largely for reversal of HRS-AKI, if the patient is eligible for terlipressin, giving it is probably better than norepinephrine, and there is some benefit as per survival. What is the predictor in this large meta-analysis? The baseline serum creatinine and the baseline MEL score, that is the severity of liver disease per se, and the severity of AKI per se, would be predictors that this patient is likely to have either very advanced liver disease or intrinsic renal disease or structural disease which will not respond to a vasoconstrictor. So point to be understood, looking at the baseline creatinine itself will give you some idea as to whether the patient is going to respond. Terli versus midodrine prosoctotide, there's no question here. Terli offers some mortality benefit. Bolus versus infusion, most Indian centers use infusion, whereas a lot of centers in the West still use a bolus infusion. We prefer infusion because it gives us a titrated effect. We can stop it early. The total dose of the drug is also reduced, and we can monitor side effects much better. So, but there is no difference in the efficacy rate. So this Covalent study from 2015 and then in 16 gave this information. What are the other predictors of vasoconstrictor non-response? So if the patient is having a baseline serum creatinine less than 3 or between 3 to 5, they tend to respond better. A poor response is there in patients with baseline creatinine more than 7. If there is no response to vasoconstrictor by day 4, please don't keep escalating the dose by 2 milligrams as 2 milligrams every 4 to 6 hours, because that's where complications will start appearing. So reconsider your diagnosis at maybe day 3 or 4. A sustained rise in the mean arterial pressure will be a predictor of response. So even though a dose of terlipressin increases the MAP by 3 millimeters of mercury, you need to have it sustained for more than 5 to 6 hours for there to be any benefit. So sustained rise in MAP rather than only a transient rise in MAP is a predictor of response. And start treatment early, don't wait. If it is HRS-AKI, splanchnic arterial vasodilatation needs to be targeted to maintain the effective circulating arterial blood volume. Because please remember, the albumin you're infusing is going to go into the third space within 16 hours, balanced salt solution within 4 hours. So you need to maintain the circulating blood volume by giving vasoconstrictors for the afterload. This was also showing information, this is Nazar et al., the delta MAP actually predicted non-response. So a MAP, delta MAP of more than 5 milliliters of mercury at day 3, which is sustained, is a predictor of response to terlipressin. Then this is Dr. Mewal's study on cirrhosis with shock, where she's looking at MAP again. I'm talking about MAP because this is relevant to the general hepatologist. You need to start looking at the MAP and the sustainability of it in your practice, even if you're not able to look at POCUS. So just to summarize, a lower MELD, a lower serum creatinine, younger patients, less advanced liver disease, sustained MAP, and is likely to result in terlipressin or vasoconstrictor response, whereas those with higher serum creatinine, evidence of sepsis, and a lower urine output, which means there would be some tubular injury, ATI, they are likely to predict non-response. I hope these are very simple take-home messages for everyone in the audience. And why we need to emphasize is don't keep incrementing the dose, otherwise we'll end up with adverse events such as these, ischemic complications in the skin, cardiac complications like sudden arrhythmias or cardiac death, and pulmonary edema, which is there in about 20% of patients who are getting high dose of terlipressin. So the confirmed trial found that respiratory failure was more common in the terlipressin arm, though there would be a component of albumin being given excessively in these patients as well. It's difficult to differentiate between the two. Biomarkers, very quickly, they are still not entered within clinical practice. Only the apex centers are having access to urinary NGAL and cystatin C. So for the general practitioner, please look at the serum creatinine with fresh eyes in the context of the sarcopenia and the muscle mass of the patient and see whether that is contributory. So anything more than 5 to 7, unlikely to respond to vasoconstrictors. But you need to be aware that the more the number of these biomarkers accumulate, so if cystatin C is elevated, NGAL is increased, NT-proBNP indicative of cardiac dysfunction is increased, these patients are likely to have tubular injury and may respond poorly to vasoconstrictor therapy and are at higher risk of complications. So early assessment of non-response, well, this is our data from PGI, where we looked at point of care echocardiography and we did it repeatedly in a large subgroup of patients. So we found a reduction in cardiac index due to intrinsic muscle weakness due to cirrhotic cardiomyopathy as evidenced by an E prime velocity. So the E prime velocity is nothing but a measure of diastolic dysfunction where the heart is beating normally, EF is high. It is in fact a hyperdynamic, hardworking heart, but it fails to relax adequately. So the E prime velocity, if it is less than 6, and therefore an E by E prime, that is the early filling to the relaxation ratio, if it is more than 12, it was a predictor of early non-response. And this has been borne out in multiple subsequent studies, and there's ongoing trials globally. So, early present non-response, we talked about preload and afterload, and I'm going to bring the heart in the matter. So, the presence of CCM itself might predict low response rates, and we may have to switch these patients to norepinephrine, especially if they have higher grades of LV diastolic dysfunction or systolic dysfunction. So, this is our data which we presented at ASLD this year. And then this was 372 patients. Again, we followed the same echo protocol. You'll notice one thing, systolic dysfunction is very rare. So your cardiologist who's telling us heart is normal because EF is normal, please go back and ask for diastology variables, SVR, which is a measure of splanchnic vasodilatation, and cardiac index. So this would actually give you more information. If you can't do it, get your cardiologist or your intensivist to do it. The presence of HRS-AKI and the presence of CCM is closely aligned. So there is an element of cardiac dysfunction which contributes to the functional injury in HRS-AKI, followed by later, in case the patient is not resuscitated properly, by tubular injury, either due to excess albumin or due to hypoalbumin resuscitation. So you need to know volume repletion. So if the patient has CCM, a good number of them would actually just be in the pre-renal state. If they are resuscitated properly, they will never go to the HRS-AKI state. So good assessment of volume status is the most important. So how do we prevent non-response? Differentiate the phenotype, appropriate fluid resuscitation and de-escalation, know when diuretics needs to be given, recognize and treat the precipitating factors, that is beta blockers, nephrotoxic agents, NSAIDs, and maybe start looking at POCUS as a good modality, start learning POCUS as a good modality. If not, the very basic predictors that I gave you would actually be telling about non-response. So my take-home message, why is there no vasoconstrictor response? Maybe we haven't resuscitated the patient correctly, wrong volume assessment. Maybe we haven't chosen the vasopressor correctly. TERLI may have had better effect or may have been associated with adverse events. Too little fluids, too much fluids, too little vasopressor, too much of it, presence of CCM, and of course the underlying advanced liver disease itself. So I hope you'll at least look at the serum creatinine and a basic volume assessment in your patients when you're talking about vasopressor response. Thank you very much. And on behalf of Dr. Duseja here, we invite you all to APASL in August 2025. Thank you.
Thank you, Dr. Madhumita. And because of the volume overload of chairpersons, some of the speakers are actually in the audience, but they will take your questions. And expert wrap-up also from Professor Reddy and Professor Wenden, and then the questions.
Okay, so it was a great session and lots of opportunity for discussion and learning. What do I take out of this? Well, clearly for a very disease-specific condition in India, rodenticide, and perhaps hepatitis A, PLEX clearly has a role, particularly in that population that are not suitable for transplant. The dosing, I think, the original very high volume was too high. Not many of us do that anymore. What the real optimal dose is, both in terms of the individual treatment and how many times we should offer it, I don't think we yet know. And just because something works early on doesn't mean that it might not be harmful if applied later on. So just as we term personalized medicine, we really need to look at phenotypes. And that's very much coming out in the critical care world now, that your response to any intervention is dependent on where you are phenotypically in your disease. So really great to see that data, and particularly the outcomes. I think the hub and spoke model, absolutely so commendable to get that referral of patients so that they are available to be treated in the right place at the right time by the right people with the right intervention. Vishali gave us a beautiful overview of how to assess volume status in our patients, and again, personalized. What you do for your ambulatory outpatient setting, what you do for your inpatient setting as they develop hepatorenal failure or renal dysfunction, as we heard in the last presentation. We've got to personalize it. You cannot say that one intervention is appropriate for everyone. The use of POCUS, left ventricular outflow tract assessment, absolutely is where we need to be going, along with, I would suggest, passive leg raising, if at all possible, rather than giving volume before you know whether someone is volume responsive or not. The use of vasoconstrictor agents, I think norepinephrine remains our first line, followed by low-dose vasopressin-terlipressin. I think we've got to get the dosing right. We've got to make sure that we don't, again, cause harm. But that real monitoring. For me, I use ProBNP a lot, and that helps me assess what the cardiac status is doing, and sometimes echo there, obviously, to separate right and left function, sometimes a PA catheter. Sometimes I still go back to good old physiological basics and look at CO2 gap between arterial and venous circulations. The elegant work presented in the last session in terms of hepatorenal failure was truly exemplary. I'll hand over to Prof. Reddy on that. I think we do need to recognize that norepinephrine and terlipressin isn't always enough. And increasingly the data on the use of methylene blue or IV hydroxycobalamin should be considered earlier rather than later. Again, not too much, just by individualizing that care and being at the bedside.
That's great. Actually, you've summarized the whole session very well, extraordinarily well. So I have little to add, except this was really a great clinic for me in critical care hepatology. And also I realized that I should really, as soon as I get home, throw over my stethoscope and carry a butterfly around my neck, because it's very evident that there's very little role for a stethoscope if you have so many functions or so many assessments you can do with POCUS. And you can do that not only in the critical care setting, but on the floor as well. You know, looking for fluid overload, pneumonia in these patients are very susceptible to fluid overload with ubiquitous use of albumin fluids on the floor. So that's a remarkable tool. And I'm not sure how many are trained in POCUS, but at least in the US now, there is an emphasis on training in POCUS at a grassroots level for house staff, at least just to look at the IVC. And then I guess as time goes by, we'll see if we can get a rudimentary cardiac POCUS as well, although I don't think we can ever get to a sophisticated cardiac assessment level as a hepatologist internist. Actually, the talks by Vaishali and Madhumita are complementary. They're just little different conditions that you talked about. One was specific AKI, HRS, where the choice of vasopressor appears to be different than, say, the choice of vasopressor in septic shock. So that's what I believe. That's what you pointed out to Vaishali. So, certainly there's a lot of advancement that's being done, and certainly, hopefully, as time goes by, with the POCUS approach, you can mitigate some of the complications, particularly of fluid overload, pulmonary edema in these patients. So I think we'll open it up for discussion. There are a few minutes out here. So if I may ask, how many in this audience are POCUS trained? Can you raise your hands? That's about 10%, right? So there's a huge need, right, to train more people in POCUS. And that's one of the fundamental things that we would need to do. So with that, any overarching comments from the panelists that you want to make?
I have one question for Professor Ethan. The data on yellow phosphorus, I mean, you have major numbers. So in a small numbers that Dr. Ravi and Dr. Samir Shah, we had published nearly 5-7 years back, we found that anyone who took more than 15 grams of the poison, all of them landed in severe liver failure, and we couldn't salvage them without transplant. So do you have any data on the dose consumed and the correlation of the dose consumed to the severity of the liver failure and associated mortality?
Thank you, Dr. Vaishali. My question is just the same for him. Can you triage the patient whether this patient will need a transplant versus PLEX? Or during PLEX, you can triage the patient that this patient will need a transplant.
I'll try. I'll attempt answering these questions. Finding out the dose of the poison consumed as well as what poison was consumed is often inaccurate in what we found. We're not able to get the correct information. That is the challenge in this field, really. But the straight answer is, I do not have any answer to that. I do not know what dose and determines a person needs transplant or not. But it's common sense that if somebody has taken a bigger dose, chances are that person will have more severe liver disease. But the challenge is often to find out what was the poison consumed and what are the dose taken. That is one question. What Dr. Mishra asked is, all of these are very serious questions and of severe implications, including legal implications. So, as I mentioned, most of India, large part of India has no access to liver transplantation. So, this topic is theoretical. In fact, in a way, a center which doesn't have an active LDLT option in India is the prime field to move forward PLEX, because there's just no other option. But then that is not addressing the question as well. Suppose transplant is possible. So that is where the data which I shared from Vijay Alexander showed that we have 3 days time. So in the meantime, if there's a transplant option possible, we should start the workup and list towards transplant to make that happen. But in 3 days, if the MEL score is more than 20% decline, then the numbers are, the predictability is very good. And you can use that dynamic predictor to say there is no need for transplant. So thereby the focus is the term now we are wanting to start to use is native liver survival. How can we improve native liver survival? That means without a liver transplantation. That is my thought on that. Thank you.
I have one more question, collating the data. So as the Gastroenterologist Hepatologist Society, should we not be pushing for stopping? Because I think UK has managed to do that. They have managed to stop manufacturing and they have replaced it with other rodenticides.
Yeah, no, these are all, we need a multi-pronged approach onto this, and the government is cognizant of that. And there have been different steps taken. The feeling is that the easy access to rodenticide is starting to get curtailed in the state of Tamil Nadu now. It's not as easily accessible. But PLEX is one of the things which is done. There's a multi-level approach is taken to that. And it's true, all of us are responsible. It's our duty to respond to this.
All right, we'll take one last question.
Or should be a PIL for alcohol then? My question to you is, do you also use NAC in SL16?
For protocol, every patient is given NAC as well. We are giving NAC as well.
Well, your time's up. On that note, we shall close the session. I, myself, and Professor Vandan would love, thank you all for your great participation and your input. So is there a break now? Is that correct? Yes. Thank you.
Now we'll break for exactly 15 minutes. See you all after 15 minutes. Thank you.